So hello, everybody. This is Bjorn with Elevate Health, and this is a community care conversation for June of 2021. And we're going to be speaking with our community partners of Catholic Community Services about youth in crisis and their family behavioral health program that they have for Pierce County. We always start out with our meetings to talk about Elevate Health's core values, and those are community, empowerment, equity, inclusion, integrity, innovation, and reverence. And our objectives today are to learn about the family behavioral health services through Catholic Community Services, programs that are offered by to the children and youth through CCS. When I say CCS, that means Catholic Community Services. Review their youth crisis services, and also make sure you know if you have feedback for us to please email at, or you can access I think it's like a form you fill out through askelevate.org. Sorry, I'm manning the weight room and doing this at the same time. I really wanted to make sure this is out since it's Pride Month. I really wanted to make sure people are aware of the different resources in Pierce County. And so this slide is here for this particularly to know of these resources in our community. And so again, these slides will be available and this information will be posted on our YouTube channel in the next few days after this recording is processed through our IT department. So happy Pride Month, everyone. Oh, not final thoughts, going back. Now I'm going to be switching slides and going to our partners here, because this would be, oops, give me a second from the beginning. Here we go. So this is, I'm going to have Rhoda take over this in a minute, but I just wanted to again thank her. And I believe Nolita Reynolds will be joining us shortly to do this presentation for our community. And I'll go ahead and progress to the next slide. You want to go ahead, Rhoda?
Sure. Thank you so much. I'm happy to be here and love the values and the mission and goals that you guys presented. So I'm really happy to be with you all. I will give a brief kind of background. We are Family Behavior Health Services. We are, and I will say, I apologize if there's background noise. I tried to get away from most of the noise. So
we appreciate your efforts, Rhoda. No worries.
Okay. So family behavior health, I believe, I'm not super historically not really quite sure, but we've been here quite some time, over I think about 40 years, and started off as just very small, actually with our family on the bottom here, with our family assessment team services, which are up to 90 days. And we really started kind of with filling a void that their mental health couldn't provide and behavior health couldn't really provide. So it's really started out as really that intensive in the home family services where if there are youth and families that wouldn't be able to really make it into an office, or they needed more intense than just once or twice a week hourly visits, the therapist was actually go out and go into the home and provide therapy there and family therapy. And so that's kind of how it started with the family assessment stabilization team. And we still have FAST. It does serve, as you can see, Medicaid. We used to be able to serve non-private or non-Medicaid families as well. Unfortunately, we're not able to do that, but we are lobbying. And so hopefully we can serve private insurance families in the future. We also offer what's called the WISE services, which are wraparound intensive services. These, as you can see, last a longer period of time. And these are for families, again, that maybe the traditional mental health, going to the office isn't working for the family, or the needs are so great that they might need someone in the home once or twice, more than once or twice a week. We can go into a home 7 days a week if that's needed. We provide a clinician. We provide what's called a parent partner. A parent partner is someone who is a parent who has kind of gone through similar things, maybe has had a youth that struggled with suicidal ideations or, extreme behavior problems. And so a partner that can kind of relate and bounce things off of. We also offer youth partners, which is kind of this in the same theme is as actually a young adult who has actually gone through maybe their own mental health crisis and are managing it well. And so that provides, someone who actually identifies with some of the struggles with the youth and can partner and actually, share some of those stories of how they coped with some of things. We also offer what's called, and, stop me at any time if there's a question, let me know. We also offer what's called clinical care coordinators, and they are kind of part of the arms and legs of the clinician. Like I said, it might be that you have a family that has very intense needs and has multiple domains, multiple things going on within their family. Might be that their their youth is suicidal and having suicidal ideations. They might be on the brink of losing their job because they had to stay home so many times with their youth. The youth might be having trouble at school. There might be siblings that are being affected by this. They might be losing their housing because they haven't been paid because they had to lose work. So there's multiple things happening with the family. And so the care coordinator kind of assists the clinician and the whole team, and maybe working and trying to find housing, or maybe working with the school to help build a program, get them into a 504 program, or which is to modify some of the school plans, or individual education program. So the care coordinator has many roles as well. We also have behavior support specialists, and they would find a role where if we have a youth that might be very depressed or suffering from anxiety, they might take them out to a park and just walk them through their anxiety, or get out and have fresh air to help get them moving and exercising, getting that blood flowing to help out with the depression. So as you said, the WISE program, the wraparound intensive service program, can last anywhere from a few months to, we've had people in our program who've been in our program for 5 years. It might be they tackled, one issue and now we're working on another, or as they've matured, there's other things that are coming up. And we do work with youth up to age 21, depending on their capacity and what their living circumstances are. So the other one,
I just wanted to interrupt you and let you know that Nolita has joined us.
oh, awesome.
Hi, yes, Rhoda's
Hi,
fully
Nolita.
capable of handling it.
I know. I just wanted to let her know, and I appreciate you
Yes.
jumping on. I know it's hard when you're juggling a lot of things.
Yeah, I think everyone here can relate, but yes, thank you.
Yes.
Sorry, Rhoda, but thank you for introducing me, Kim.
No, thank you. So the crisis team, so Nolita, I've introduced Fast and Wise. The crisis team, we hold and have for some time, and Nolita, you can jump in, the the crisis contract for the state of Pierce County for youth 18 and under. Sometimes, like I said, we serve youth even in the crisis that are a little bit older, but any youth that have gone into crisis within Pierce County, we will respond. And I will kind of define a crisis in a sec. As well as we will respond outside of our county. If a Pierce County youth ends up for whatever reason at Children's Hospital in Seattle, we will also respond to outlying counties, as well as if a King County or Thurston County youth ends up in one of our hospitals, or even within our county, they might have a crisis at a grocery store and they're in a different county, we will respond to that youth to try and stabilize that crisis at that time. Nolita, I'm in a park, so people might be walking around, but so we serve, we provide crisis services to anyone. You don't have to, like I said, 18 and under, no matter what their insurance is, whether it's private, Medicaid, or no insurance, we will still provide those crisis services. We are available, 24/7. I don't like to, that term seems so big, but it actually is 24/7. You can call us at 3 o'clock in the morning. You can call us at 3 p.m. in the afternoon. It doesn't matter what time the crisis is. We will respond. We have a response time per contract. It's 2 hours, but we really try and get there within an hour. That's our goal. And you will have a clinician out there and working with your youth and your family to try and our best to stabilize that crisis and provide whatever services we can do. We average up to 50 to 80 referrals, crisis referrals per month. Last month it was the highest that we've had for quite some time. And I think it was like 112. Is that correct, Nolita? Yeah.
It is.
Yeah, our crisis workers are pretty busy, but it's important that we do respond to the crises that are coming up. A crisis can be really anything that the family defines as a crisis, within the parameters. The majority of the crises that we get are youth that are struggling with depression, severe depression, where that they are having pretty intense suicidal ideations, thoughts of suicide. They might have had an attempt and are either hospitalized, and we will meet them at the hospital. They might have self-harming behavior, such as cutting, banging their head, any form of self-harming. There may be extreme behavior issues, such as throwing things, being violent, hitting others, things like that. Those are so we respond to the crisis at that moment.
So Rhoda, I'm going to interrupt again. I'm going to push
Sure.
out a poll just to see who in our audience has either worked or lived with somebody, a youth in crisis, just to see with our folks that we are working with, or are not working with, but have on the call today, to see our audience. We have 8 people that have responded. Let's see if we have any more. I'll hold it up for a few minutes. Not a few minutes, a few more seconds.
I also want to add something just kind of about the
Yeah,
last couple of years when you have a moment.
sure. And just hold on for a couple. It looks like the majority that have answered, 89% have either worked or lived with a youth in crisis.
Oh, wow.
So go ahead, Nolita. I like to do polls every once in a while because it helps us know who why people are here on the call. So
yeah,
absolutely. So something I just wanted to say, and news to no one, the last couple of years have been, or last year and a half has been pretty unusual. And one of the things that we saw that happened in Pierce County with crisis services, and if you said something like this, actually in all of our services, Rhoda just cut me off, is that we had a pretty sharp decline in referrals, and it was most dramatic for a longer period of time with crisis services. And so, I mean, one of the examples I've given in some other community meetings, in May of 2020, we had 12 crisis referrals, which is lower than we've ever had. In August is our slowest month. And then May, it was 112, which is higher than we've ever had. And so we have made some adjustments to try to respond to the pandemic and just to be sure that we're getting everything coming our way that we can. And so we did work with the crisis line just to have them send more referrals to us directly from the community, because we're certainly hearing from family members about the strain and stress of everything that's going on. And I also just wanted to let the audience know, if you call the crisis line, we are going to talk and talk it through with you and triage over the phone. And it doesn't make, the vast majority of them, 70–80%, we do a face-to-face, but there are some that we through on the phone. And so we may work to do that. If you do refer and you're calling for somebody else, it doesn't mean we're pushing back, but we are asking questions to get clarity and make sure that we're being most responsive. Now, when a family calls directly, it's a little more straightforward and we just work through that. But if any of you guys have called the crisis line, I guess I just wanted to put that out there, because there's a couple times that it would maybe more from EDs that we've had a little bit of feedback. They're like, well, your staff are pushing back. They're just trying to get clarity so we can make sure our response is the most tailored. So I just want to add that little caveat there around crisis services, and that we are no eject and no decline. And so ultimately we had something come up earlier this week. We just sent someone out. It didn't seem like it was needed, but when it came down to it, it's like, you know what, let's just send someone out. We'll figure it out. So that's what we'll always default to, despite all that. So
Great, thank you. And let me know when you want me to go forward in the slides as well.
And I will say this is mostly tailored towards crisis. This slide is not, so we may spend some time here,
Okay.
but the subsequent slides do refer kind of to our practice model that applies to every level of service.
Yeah. For the group, I was sharing with Rhoda before we started that often our crisis services are presenting to providers in emergency departments, because they're the ones that are really receiving people in the community and know how to and try to connect them to everybody. So this is really an opportunity for the community to hear about these resources and know how to access them yourselves. Can you talk at all about maybe how you serve in the schools or other areas of the county?
Yeah, and Nolita jump in, but I would like to encourage if there's not a medical need for a youth to go to the hospital, please reach out to us and we'll respond. We can respond, quickly. Like I said, our goal is within an hour, and there won't be such a late. If there's not a medical need and someone decides to take their youth to the hospital, then you have to go through the hospital procedures, probably wait in the waiting room for hours, and then wait for the social worker, and they have to do their whole assessment. And then they call us, and then we'll come out, and that might take another additional hour or so. And so a lot of times we meet families in the hospitals and they're like, we're ready to go, because they've already been there for 5 hours when there's not really a medical need for that. The child wasn't hurt. So that's what I would like to encourage the community to please reach out to us directly if there's not a medical need. It's not necessary. On top of that, like you said, we also will go out wherever in the community. So schools, we've gone to many schools where the teacher would call, maybe someone's feeling suicidal, they have not harmed themselves, or even they might cut themselves superficially, but it doesn't need medical attention. We will respond to that. The requirement that we have so we can adequately safety plan is that a parent or some type of guardian either be there or actually be on their way there so we can meet with them. Because really the goal is as much as we can to do what's least restrictive and safety plan and get them back home safely. And we're not able to do that if there's not a parent there that we can safety plan with.
So just to clarify what least restrictive is, because that's language that we use as providers that maybe our community members don't really understand.
Yes, thank you for that. Least restrictive really means that whatever is the lowest level of care that is safe. So if we can safely, if the family and the community and possibly with our assistant, if that child can go home safely instead of being hospitalized, that is actually the goal, because we statistics say that a child does better at home with their family in their family environment than in a hospital setting. Now, there are extreme cases where a youth does need to be hospitalized. But I would say really 90% of the time, there is a plan that can be put into place.
Something I'll add to that.
Yeah, please do, Nolita, please do.
So yeah, our goal is first to find a family and a community solution. And one of the things that does happen with families, and I don't think this is going to be a surprise to anyone on the call, is families are pretty exhausted and often requests for hospitalization, or maybe sometimes can they Raymond Hall take them, or can they go to foster care, is a parent saying, I need a break. And it can be hard to say, hey, can we come work in your home? And they may just like, I'm sick of this young person. I need this child out of my life right now. I've done this 3 nights in a row. I'm tired. I have other kids to worry about. And so we sit there and talk it through and try to find ways that we can remove the barriers and help educate them about truly the child is going to get, I see you've been there. That at home, and it's going to be harder, and is there a way tonight we can provide you rest and relief, because you could still in the morning decide, I think my child needs to go to the hospital, and that's best. But let's see what we can do right now, because even when they go to the hospital and they still have to learn how to come back and live at home with their family, even for youth that go to residential. And I think some of the examples that Rhoda's talking about, where we do worry, is I remember one of the few times where I was trying to talk a family into having their child go to the hospital because the youth was having command hallucinations, saying he wanted to kill his mom and his sister. Mom's like, I think we could do it. And I said, gotta tell you, I'm pretty scared about this. And so we will push family members, but like Rhoda's saying, the vast majority of the time we can safely do it. And there have been times that we've gotten into a referral, we were like, yes, we could do this at home. And we had this young man, he was having some psychosis and we were working through it with him, but his thing is he would just keep wandering. And so finally we said, you know what, this isn't safe. And we partnered with them to get the youth to the hospital. So we want to be that bridge. And I think one of the ways that we feel confident about doing it is because we can be very actively a part of it, up to being in that home with the family. I mean, most of the time we don't have to do that, but I wanted to clarify for people, part of what gives us that confidence is if we do have to have a wake staff or providing things like door alarms and lock boxes, really structuring supervision, or maybe the layout of the home with the family, because sometimes it's smaller things that can help. Sometimes a night's sleep can be the difference between this child has to go to the hospital and okay, maybe I can do it. And then we see it as our job. How do we help remove those barriers and get that family to that place?
Great, thank you. I see there is a question from Nancy. Are children hospitalized at Mary Bridge or Fairfax?
Both. I think now I'd say at the ABHU is much more common since they've opened, but they'll still go to Children's and Fairfax as well. But now it's definitely shifted to the ABHU.
And the
is the adolescent behavioral health.
Yes, sorry.
Yeah.
Mary,
and that's and that's affiliated with, it's not a part of Mary Bridge, but a lot of the youth that end up in Mary Bridge, if the adolescent behavior health unit, if they have availability, they will go there first. And then, like Nolita said, Children, Fairfax, and there's, I think, one Smoky Point up north.
Yeah. I also from my background working in the hospitals prior to coming to Elevate Health, I want to prepare families a bit that even if your child ends up in the emergency department and is assessed to need higher level of care, which would be a mental health hospitalization, they could be in the ER hours to days, weeks, waiting for a bed. And that is really hard to say, let alone hard to actually have my child be in that situation for a long period of time. But that is kind of the state of our mental health system, and why there are services like Catholic Community Services who really do that more intensive wraparound to really help support families and the children in their home environment, and help families really understand what this crisis is, give them the tools to help the individual do their best in the outpatient world. And please add to that, ladies, if I missed something or I misspoke.
No, definitely. And we've seen this, I think, Nolita, more often in the last couple months, I would say, where there have been children that have been admitted to Mary Bridge for some mental health crisis and have really stayed there for quite some time. And then really trying to get together with that, whether it be a mental health disciplinary team meeting, for different community providers get together and say, hey, what is the best thing for this youth right now? They've been in the hospital for a week. Is there a way that the crisis team or Catholic Community Services, other programs might be able to come in here and help stabilize to get the youth home? But yeah, there has been at times a long waiting period, and it's difficult because the emergency rooms aren't a mental health facility. Yeah. I think there was
Yes, I'm looking at the chat right now. It says, so if I'm working with a client with a child in crisis, could they call you all, CCS, directly for triage for hospitalization ? Or go to Mary Bridge and have to go through that process?
Yeah, I did answer there on that one. Yeah, they could call.
Oh, sorry, I didn't see that.
That's okay. Yeah, no problem.
Okay.
I mean, maybe not everybody sees it. So yes, it tends to be a better way to go, because what'll happen is they will go through that whole rigmarole, getting transported, or even if EMS or police come out and they'll take them there, they go through that process, and we're maybe getting a call a couple hours later. And so if we can, I mean, we always encourage people to call us first, and I think EMS and law enforcement are happy if you do that as well.
Yeah.
So, yeah. And so we'll try to provide things like, even, can we stay on the phone with them, call them at the scene while we're on our way out there, and different things like that, just to help ensure a continuity of care and a connection with the youth, depending on what the acuity looks like in the situation.
Mm-hmm.
I mean, obviously, if somebody's like severely physically injured, we're not going to try to swoop in and mitigate that. But a lot of times things, with young people that can come across as pretty big, can be managed for the most part. It can look pretty big, and then it can get pretty calm again. So
Does CCS provide any classes or support or anything particularly for parents and families when they're working with somebody who may have more of some chronic / acute mental health issues?
we don't tend to do formal classes,
Okay.
but psychoeducation is absolutely a part of it. In fact, even, in terms of audits, it's like they have to get a diagnosis to qualify, and part of the job is to educate them about the diagnosis. Obviously, that's not going to tell them how to address it, but psychoeducation is a huge part of it. And the work, especially with WISE and FAST services, they have family team. And really the goal, a treatment plan needs to be very needs driven, solution focused. How do we get there? And a lot of times the biggest thing we're doing is helping families practice that, because a lot of times, again, what do people do? They tend to go to what they know or what they have the energy to execute, basically. And so sometimes we have to help them practice a new way. For any of us, learning a new habit, learning a new approach is going to take time. And so it is a whole kind of, it takes a village to get them going down the right path. And, you know, if their child's been at this for 7-8 years, it's going to take us a little time to kind of help the family redirect it. And we really do work with the whole family. And so sometimes that's a conversation as well. Sometimes we hear, hey, my child needs this, we don't. And it's like, you know, the reality is child behavior doesn't exist in a vacuum. It isn't blaming and shaming parents, caregivers, but it is that we're going to have to work together to on that road. That's just the reality of family dynamics.
Absolutely.
It looks like somebody has a question. Michael.
Hi, my name is Mike Willie. I'm the Battalion Chief of Emergency Medicine with West Pierce Fire. We cover Lakewood and University Place. Nolita, thank you for mentioning that you would hope that that the crisis team is being contacted as an initial approach vector. For our people, that's a message we're trying to push kind of more and more, that the emergency room is not going to be the most effective route for a lot of these situations. Obviously, like you were saying, if someone's injured and needs medical care, that's one thing. But to have your folks as a reference, or a resource rather, is incredibly important. And I wanted to put it on everybody else's radar as well, that it seems like the playing field on our end is kind of shifting. We had a meeting with one of the deputy chiefs from Lakewood Police Department last week, and this is just coming up into the police and fire circles, but there has been recent legislation passed at the state level that is greatly hampering the police's ability to physically detain people in short term. And they're going to be extremely reluctant to be using involuntary commits as a mechanism to help individuals in crisis. And we're going to be kind of caught in the middle of that in the fire service, because now without that legal support of having an involuntary commit, we cannot physically restrain anyone. So if somebody wants to get out of a medic unit on the side of the road, we now legally have to pull over and let them out. And so I think on our end, we definitely want to continue having deeper conversations with the crisis team on how we can integrate our services with the crisis team to present that as an option to individuals and families on scene as a primary avenue for trying to address crisis, rather than saying, no, you got to go to the emergency room, you're threatening to harm yourself, and try and have this pitched verbal battle with somebody. So we really appreciate that, and I'd really like to kind of pursue that, but I wanted to put it on everybody's radar in the social services side that we're probably going to have to start really leaning on your services a lot more, because we're losing a lot of our vectors for trying to get people in crisis to services. So,
Well, Michael, it's wonderful to have our first responders part of our conversation. So thank you for being here. And I know there's always challenges for certain, and having conversations is the way to start, and certainly partnering with our crisis teams. So that's one thing for the community to know, that we do have a lot of meetings and coordination and collaboration with each other to try to best serve our community. And once we get a barrier like this, we look for solutions to that barrier. So but this one is one that is hitting our first responders a little bit of a challenge right now, making sure people are getting to those services that are needed. So
Kimberly, I was going to
yeah.
have you just maybe pop to the next
next-
slide or two, just because it will be relevant to it's overall, but kind of some of the things
Mhm.
stress and deal with, some of the things that we may ask about.
Can we talk about safety planning a little bit? You know, we as clinicians, we understand safety planning, but a family member or somebody who's working with a youth member may not understand exactly what that is, because in their brain, they're like, the person's not safe, so I need to take them somewhere. So understanding what safety planning is in the home would be probably helpful.
Okay. You want me to start, Rhoda?
Yeah.
Okay.
Yeah. So,
Go
oh,
ahead.
go ahead, Nolita.
Okay, I just was going to say, for all of the families we serve, we have to have a written safety plan. And it's one of the things that we do, that we collaborate with the family strongly, but one of the things that we're often saying internally, because we're very strengths-based family and youth voice, and this has actually come up a couple times internally. Like, for example, they said, well, the dad doesn't want to put away his firearms. He had multiple firearms. His son was threatening suicide. And then the clinician or the support staff that was there said, well, that's the family's voice. And it's like, okay, so one of the things that we say, the safety plan is probably our least strengths-based document. And it's an area we tend to be a little more directive in. And so we absolutely have to be clear about what the risks are. Now, sometimes there are things that maybe somebody said, well, you know, their issue is aggressive acting out, but like 6 months ago, they had a suicidal thought and maybe kind of dabbled in some planning. We still put it on there as a lower risk factor. But also with this document, we want to make sure that we are talking about behaviors, the kind of the who, what, when, where, the frequency, intensity, and duration. And then we look at the factors that will help mitigate that. So preventative strategies and then crisis response strategies. And they need to be pretty clear and well, not pretty, they need to be clear and concrete. And so we're looking at things like the youth is feeling like, you know, they're saying, I am suicidal, I have a plan. They had, then we would put like the number of recent attempts and how. And so we're going to be looking at things, pretty standard language about locking up sharps in the home. We always ask about firearms when we're asking, if they say they're put away, where are they put away? Oh, they're in a safe. Is this a combination lock? Is it biometric? I was on a call last night where the family had a safe, but it was a glass front. So it was actually more of a display case. And so we end up asking people, can we see what it is? And it can be tricky because sometimes there's conversations about Second Amendment rights, and we don't argue with people's right to have things. What we do is we sometimes talk about having deliberate myopia. We just want to keep your child alive. I know you're confident about this. What if you're wrong? And again, things like firearms and hanging, you can't come back from. They're very quick decisions, if you will, and it's harder to come back from something like that versus an overdose. Again, I'm not minimizing any method, but we really get in there and have honest, candid conversations with family members about what risks look like. And we will say things, my goal here is to keep your child alive. I'm worried about this. I can't leave tonight if we don't have a solution that's going to feel safe to me. And that's kind of part of the coaching and I'll say psychoeducation we provide families, because we can all get used to any situation. Families get inured to the crisis. And so we're kind of there to help reflect something different, what our level of concern is. So we might say, look, then do you mind if we have somebody stay here until your son goes to sleep? Let's say they're pretty confident the child's going to sleep through the night. Or maybe there's going to be a sleeping arrangement made since he might be sneaking out of the second story window. I mean, we can do door alarms too, but sometimes like people sleep in the living room that night. So again, very specific strategies to deal with specific risks. And so we're negotiating that, but we're not compromising on the particular risk. So I don't know if that gives people a sense of it concretely, or if you want to chime in, Rhoda.
Yeah, I would like to add to that. Well, it's really just a written plan that's based on the family and what the family needs are and what the family is able to do. We won't ask them to I don't know, provide a iron lockbox or something like that. It has to be realistic within that family, and really simple enough that everyone understands what is the risk, what what are the steps that are to be taken, and who do we call if in fact that risk occurs. And so it's really I want to say that it's intended to be simple but very thorough at the same time. We don't want to make it too complicated where if something does happen, someone can't read it or someone doesn't know what to do. But we do want to make it very thorough, so if something does happen, they can look at the safety plan and, okay, this is the risk, this is how we're going to respond, this is what the youth is going to do, maybe helping to calm them. They won't listen to music, so reminding them, hey, how about get your earbuds on and listen to your favorite song. And like I said, what are the steps to be taken if in fact that risk does occur. And it's done with the parent, guardian, the youth, and anyone else that is involved within that safety plan.
Great. Thank you so much for kind of talking
Okay.
about that. It's an important piece of working with families and again, keeping people safe.
I would also add, it is important to, for a lot of families, we will do a safety plan with them and everyone has, agreed to that. And then it kind of goes like in a drawer and kind of forgotten about. And then a crisis occurs and they kind of forget to go to that. So we often ask, suggest that families put it in the refrigerator or put it like, somewhere that if a crisis does occur, you'll see it. And we even have families, okay, let's practice this. If this A happens, then what's going to happen? So they'll become more familiar with it.
Yes, totally agree with you on that one. Where do we want to go next in the discussion? Do we feel like there's any other slides or go ahead.
You can move forward to the next slide. Just a little bit about our values. And sometimes one of the things we'll talk about internally with our staff, if you don't know what to do, kind of go back and look at some of our guiding principles. This is a few of them. Again, this is a little more focused on the crisis end of it. And of course, focus on safety first, always, always, always.
Yeah, and definitely, like I was saying before, we work with the entire family. It's not when, you have someone in a crisis, whether it be a youth or a parent or even the dog sometimes, it's everyone's crisis, the family crisis. And I'm kind of joking, but really not. I mean, people are very attached to their animals, and we've had calls come in because the dog passed away and a youth is feeling suicidal. But the point is that we work with the whole family. And like Nolita was saying, always safety is our first goal. And like she said before, just to reiterate, we have had to have some pretty strong conversations with some family members who that maybe their 5 previous attempts might have been through overdose, and the guardians are reluctant to lock up their medication. And it's like, really, what's more important, your medication being easily accessed or your child being alive and not overdosing? We try not to have those conversations, but sometimes we do have to be that blunt, really. Always strength-based. We really try and do a full assessment and put in that safety plan and the assessment the strengths of the family, whether it's maybe the youth likes to draw or they like poetry or the mom likes to sing songs, whatever that their strengths are, we try to build them into the plan. And solution focus, not what do they call that, like idolizing the problem, but really let's move on and see what the solution is and move forward. And also, especially in crisis, but I would say in the other two services is all, always our families are often dealing with other organizations, other community partners. And so it's really important for us to collaborate with those other organizations, not only to build them the support up for the families, but to make sure that we're working collaboratively and not against one another, not that we're working on one thing and they're working on the other opposite, that we can work together. And then I did talk about our youth and peer supports, and in every one of our programs, as it applies, that we provide youth and peer supports. Nolita, did you have anything to add to that?
I just want to add something. I was also answering some questions in the text, the chat, that one of the things that does happen sometimes, we do always ask, and actually I think on the next slide, it's on there, like kind of some basic questions we'll ask you as a family enters into services. We do ask who their current mental health or SUD provider is. Sometimes people don't know, or they'll say they won't have one. And then we've gotten a call from another organization saying, well, this youth came in and now you're serving them through crisis, or there's a fast referral and they're open with us. We would prefer to have them work with their existing provider. It's better for the family. The continuity of care piece is critical, important. So we want to do that. So we do try to find out, even if they just say, oh, it's someone at Greater Lakes, we'll call Greater Lakes and try to track it down. And so I just want to be clear, we want that to happen. Sometimes there's youth that maybe have a community psychiatrist or some other involvement. And the way we work, being a little different, very community-based, sometimes there can be some miscommunication or misunderstandings of it. My plea is pick up the phone and call one of us, email. And if you email, I'm going to say you might have to do it more than once for me because I'm just inundated. So calling is better. Even shooting a quick text. I think my contact information is at the end of the slides, and Rhoda's as well. To say, hey, is this youth in your services or worried about it? I'll actually drop a lot of things to return those calls because it is so important that we're working together as a community. And our hope, whatever our level of services wise, which tends to be 18 months-ish, more or less, or if it's a fast or a crisis service, we want them to be able to transition to a lower level of service or stabilize and be done. Because we work with that tip of the pyramid, high chronicity and acuity. And so that's our niche. And we absolutely do want to transition them to other providers and something that's more normative and community-based.
Yeah. Great. Should I go to the next slide?
Yeah, it just breaks down again.
Okay.
Yeah, specifically the process for accessing crisis. I mean, we've had calls, people say, hey, how do I get a WISE? And we'll tell them. I mean, we'll talk.
Mm-hmm.
And then it does go through that we provide a written safety plan. This is at the heart of any of our referrals as well. We do have psychiatric services that have to be connected to an existing service. For crisis services, I'll just say we have to have it available per contract. What our medical team tells us is there's not a lot I'm going to do in this space of time. Medications take time to build up in the bloodstream, et cetera. So we really try for our briefer services to keep them connected to the community provider. We'll do consults. Sometimes if they're getting prescribed psychiatric medications by a PCP, or somebody doesn't feel comfortable with it, maybe they've called the PALS line, our psych team can provide consultation to them as well. So anything that we could do, again, to keep it the least restrictive, the more kind of ongoing supports, if we can provide that support without having them see our psychiatrist. We do, obviously, especially in our longer term services, have families that are in there. We have capacity, which is nice. So all these things we always say one size fits one for each family. So somebody might say, well, my friend down the street, they got lock boxes. Can I get that? Or we'll have an ED call us and say, hey, can you just go to this family's home and replace their doorknobs for them? They don't want anything else. And it's like, okay, that's not the service we provide. It's a component, it's a strategy in the context of, a service array, if you will. It's not a la carte.
Yeah, that makes sense. I'm just aware we have about 10 minutes left. Is there any success stories or any, obviously being mindful of any, protected health information, but any success stories that come to mind that be pertinent to share about maybe somebody who's been in crisis and the services that were provided and having a good outcome?
Yeah, I mean, we have several.
I'm
I
sure
think,
you have lots.
yeah, I mean, every day I think that we can get a youth home safely in crisis. I feel like that's a success story, but I guess a particular one, and Nolita, you're familiar with this youth, actually went through the crisis line several times with suicidal ideation, suicide attempts, was actually hospitalized for a period of time. So we served her through crisis, and we also served her for a fast, and she was in and out of our program periodically. She also had an eating disorder that we were working with as well, and worked pretty collaboratively with her doctors and other providers. And just recently, she graduated from our services. She turned 18. She graduated from school. She has a job and is really doing well. And so those kind of stories warm your heart. Well, I remember 2 years ago getting a phone call saying that she had written a suicide note and she had a definite plan. And so just seeing, her blossom, a lot of hard work, mainly with her and her family.
Yes.
But being a part of that is just a great honor, and the family never gave up, and providers never gave up, and definitely we were not going to ever give up either.
Yeah. And I think that's important for families to hear, because sometimes they're in the thick of it, and it's so discouraging when you don't see fast or significant change in a short period of time. And knowing that this past year with COVID, we see a huge increase with anxiety, especially in our youth, and some depressive symptoms, that not to give up hope, and that using the tools, using the services that are available in our community are really important, because people can recover, they can get into remission with their illness. And so I just always like, because when we get into these conversations, it's always good to end on a moment of positivity and hope for our youth, because we've all had definitely a hard year. I just want to is there anything else that the two of you wanted to present before I come back to the community and ask for some final questions?
I think questions are good.
Okay.
Like 5 minutes left.
And I have a final poll too. And if you all don't want to chat and you want to take yourselves off mute and ask your question, by all means, you may do so. I'm kind of looking at many things here. And Nolita, I appreciate you keeping an eye on the chat, as well as seeing hands. I'm going to go ahead and do my final poll for everybody. Let me see here. So mainly it's asking about, was this helpful? And if you want more information, I would please ask you to put that in the chat so that we can make sure additional information could potentially be given to you. We have 7 people who have answered. All right, numbers are coming up. So far, everybody is saying yes. I'm glad. We have 9 people. We'll keep it going for just another few seconds.
And I'll just add is that, you know, we're always can make time for presentations, to go out to the community, talk to parent groups, we've done presentations for police officers, EMTs, firemen. We just want to people know that, you know, our services are out here and available. And so wherever we can kind of get the word out and help people know how to gain access to the services, and, you know, we will make ourselves available.
Well, I don't see any other questions. I did do the final slide. So for those of you who want to write some things down, there's Nolita and Rhoda's contact information. The crisis line is also a very important number. So make sure you have that. And I appreciate everybody showing up today. This is one of our larger groups that we've had so far. So obviously, an important subject for our community. And I truly appreciate Nolita and Rhoda, especially Rhoda, for pulling over to the side of the road in the beautiful mountains to talk to us today. So
Yes, thank you, Rhoda.
and I thank you both for your service. Nolita, you've been here a long time. Rhoda, I'm not sure how long you've been there. You may have been there just as long, but I just know Nolita's been a true advocate for children and youth in our county, and we appreciate all of her hard work. So thank you, everyone, and have a wonderful rest of your day.
Thank you. Thank you for having us.
My pleasure.
Bye-bye.
Bye.